Everybody. My name is Tom Branigan, and I'm the medical officer providing occupational health services to the Irish Air Corps. I sit on the board of the Faculty of Occupational Medicine as well as the LFOM member. The LFOM is a kind of an entry-level qualification in occupational medicine for doctors, licentiate. It's achieved through a series of exams. You would probably, as a first point of call, want your doctors engaged in occupational health to have done that qualification. There's also a diploma, which is of equivalent standard but slightly lower, and is not required for members of the faculty. And then there's a higher exam called the membership exams, which is a much more robust examinations process before you become a specialist and admitted into the faculty that way. So I'm going to give a brief overview of occupational health in Ireland, and relate it a little bit as well to human factors and ergonomics, particularly within the Air Corps, which is the place where I work full time. So we'll kind of start off with what is occupational health all about. So the general principle really in occupational health, it's applied to a fitness to work assessment. So you would be considering any medical considerations, ethical principles, legal considerations, health surveillance, health promotion, and general principles of rehabilitation. All those kind of things would come into play in your decision as an occupational health physician. You've got the relationship between people's work and health, how people might be accommodated in work where they've got particular additional health care needs, making sure that the workplace is not injurious to their health by employing preventative strategies. You might consider how some people's health might be affected by their work, and it would definitely be a multidisciplinary team approach where there is a team available, which in some places is better than others. I will talk specifically about the Defence Forces because I'm in the Defence Forces, but I can give you a bit of an oversight as well as to other locations that may be better resourced or not quite as well resourced. The medical fitness for work interview, it doesn't just focus on the medical condition itself. An occupational health physician or the occupational health service wouldn't typically be managing somebody's medical condition. They would typically be managed by primary care or secondary care specialists, so their GP, or if it was a heart condition, they'd be managed by a cardiologist. But the occupational health provider is more focused on the associated loss of function, any resulting disability, and any reasonable accommodations which might allow someone to continue working when they return to work. Occupational physicians would typically not have a therapeutic relationship with patients referred to them, but they do have to have an understanding of the therapeutics to make appropriate recommendations with respect to fitness for work. Now that is the theoretical ideal situation where the occupational health physician is not managing a patient's care. In the Defence Forces, we are a little bit different because sometimes the occupational health physicians, the medical officers, we do sometimes manage people's primary care needs, so their GP needs. It is part of the job, and it is understood to be part of the job. So it's not like we're breaking any rules in doing it, but it's not the theoretical best case scenario. So as a multidisciplinary team, there's a lot of other occupations, a lot of other specialists that might contribute to the overall service. So a complex interface between work and health, and then you're trying to maintain this fundamental right to health at work. The kind of specialists that might assist in the decisions they might make recommendations. You've got occupational hygienists, toxicologists, you'd have occupational health nurses, occupational health physicians, physiotherapists, occupational therapists, ergonomists, environmentalists, engineers, health and safety workers, counsellors, and occupational psychologists. We'd have social workers. Even within the Defence Forces, we have a consultant psychiatrist on the staff who provides occupational recommendations around people who've got mental health issues. And I think we're quite unique in that respect, I think, in Ireland, that we have access to a specialist on the full-time staff in that particular area, whereas a lot of other services would have to refer outside. So all these people are working together to achieve the greatest standard of health for all workers, and trying to intervene at the earliest possible stage to ensure that health is maintained and make recommendations there. So what do we really concern ourselves with in occupational medicine? So it's preventative care and risk management. You're doing health screening. That kind of health screening can cover a lot of different things. Standard induction medical sometimes into employment would determine somebody's medical status before they join to make sure that they're fit for that job. The kind of things that you would look at would be people's ability to hear, people's visual acuity, their color vision, if that were relevant. And it is relevant in certain fields, such as working as an electrician. Driving pilots have certain standards when it comes to color vision, and air traffic controllers have an even higher standard. They essentially have to have perfect color vision. So all those kind of things will be looked at, and then they will be looked at on an annual basis thereafter as well. If you did notice a deterioration in anything, then you might be inclined to refer them or ask that their GP refer them on to see a specialist in that area and try and bring them back to the required standard. Bloods could be checked. Within the Defence Forces, we do a full array of bloods every year, which includes kidney function, liver function, cholesterol, inflammatory markers, your blood cells, full blood count, which is red cells, white cells. We check calcium, magnesium, phosphate, gives some sort of indication of nutritional deficiencies, and we have the capability of checking a lot of other bloods on top of that as well if we need to. Certain people would have thyroid deficiencies, and we check those. Patients over 50 would check them for prostate specific antigen on a blood test and follow it up with an exam if necessary. So we do a lot of those things. We can check. An occupational physician can have a look at somebody's ECG, which is a cardiac tracing, to see if there's any detectable issues with their heart around electrical conduction. Some places there could be grounds for doing an X-ray at certain points in their career. Certainly for UN service, a lot of our patients are obliged to do a chest X-ray before going away, and that's not really necessarily because of Irish personnel travelling, but I think it's to capture tuberculosis in other countries where it might be endemic, and so the Irish get asked to do an X-ray just to because of an overall UN policy in relation to that. The occupational physician then would make determinations around fitness for work, fitness to continue working. If somebody has just been off work, that the kind of rehabilitation plan that you would need in place to bring them back into work, any kind of reasonable accommodations as well might be recommended by an occupational physician. But they'd also, reasonable accommodations is also would be within the purview of an employee assistance program, sometimes human resources, and any of the other specialists that I mentioned there on the previous slide. Everybody needs to be mindful of regulatory compliance, and there will be certain legislation that we would have to adhere to and make sure that we don't fall foul of. Particularly here in the Air Corps, we have the safety, health and welfare at work. There's quite a lot of different parts, and there's also EU regulations with respect to pilots that we have to follow, and that it stipulates precisely what we do as part of the health surveillance for them on an annual basis. And if they fall foul of that, they're grounded and they can't fly. Same goes for air traffic controllers. Commercial divers is another aspect that we encounter quite a lot of within the military, where there's specific legislation telling us exactly what we need to look at and how frequently we need to look at it. And then within the role as well, if there's an opportunity to do so, there's health education and promotion. You can run, it would again fall within the multidisciplinary team to run smoking cessation clinics, weight loss, getting people active, reducing alcohol, and working on people's mental health, having welfare days, things like that. It also falls usually to an occupational physician in organisations that have ill health retirement meetings and ill health retirement decisions to prepare sometimes those files or to sit on boards to make those kind of decisions. So ill health retirement would be where due to illness a person reports an inability to continue in work, to return to work in any capacity, and essentially is removing themselves from that particular working environment, possibly to not work anywhere again. Sometimes people go on ill health retirement and then apply for disability benefit, and then they're into another assessment with another department, which employs doctors as well who are practicing a form of occupational medicine, sometimes in a specialist capacity, sometimes not. So there are benefits then to having an occupational health service. There's benefits really for everybody involved, and the employees themselves, they get the benefit of having ready access to screening tests, ready access to a competent physician who is able to advise them on many different aspects of their health. So in general, it has advantages to improve the employee's health. Um, people can get into awful bad habits, so it's quite useful to have somebody even once a year uh, point out where you're deviating a little bit into unhealthy behaviors, so that you have an opportunity on an annual basis to have that conversation, and might just over time spur people into healthier behaviors. Um, for the employees, it also maintains them at a healthy level so they can continue working, and continuing to work means they can maintain their earnings. Um, even though people can retire on ill health grounds and go on disability benefit, it usually would not be they wouldn't be as well compensated as if they were to remain in the workforce in general. Um, from the perspective of the workforces, then you're reducing absenteeism, you're reducing presenteeism as well, and improving productivity. The employers benefit because the employees are more often in the workplace, so there's greater productivity, and that really can hit the bottom line. You don't if you're employees who are off on sick leave, particularly for long periods of time, it's very disruptive to workforce planning, and quite difficult to manage. So overall, where you've got a healthy workforce, you've got a benefit to the bottom line, and that helps the economy to grow, reduces the costs of healthcare through the fewer referrals into secondary care, fewer hospital admissions where people are adhering to healthy practices. So there's lots of benefits to it. The doctors that practice are uniquely trained professionals, so they're delivering kind of evidence-based support for employee health and well-being and organizational effectiveness. So the businesses really do benefit from this in terms of improved productivity. Certain companies where they bring in occupational health services where they previously didn't have it are able to calculate based on absenteeism and the reduction in absenteeism. They can really calculate whether or not it was worth it, and they typically do find that it is worth it. Certain small measures, even just knowing that you have access to this, and you can bounce things off a trained doctor and talk about you might be able to what you might be able to do and the reasonable accommodations that an employer might be able to put in place to allow you to do it. It can have huge benefits really in the long term. So the access to occupational health in Ireland is an important thing to discuss. I have a couple of slides on this, but I'll talk around it as well a little bit. If you want to consider that there was a European publication from the European Commission there in 2017, the Pillar of Social Rights. So you see there, and I've put them all on the in the image there. But you see number 10 is a healthy, safe, and well-adapted work environment and data protection. You can see all those yellow ones are a little bit peripheral to occupational health. Good work-life balance, social dialogue, involvement of workers, information about employment conditions, protection in case of dismissals, wages, secure and adaptable employment. So these all sound like the kind of things that you'd want in your workplace, and they essentially are enshrined in here as according to the European Commission, you have a right to these things. There's an EEC directive, then the Occupational Safety and Health, the OSH framework, and that translates in Ireland into the Safety, Health and Welfare at Work Act. And then you've got a Charter of Fundamental Rights of the European Union. Article 31 guarantees every worker the right to working conditions that respect their health, safety and dignity. And then the EU Charter establishes that everyone has the right to access preventative health care and benefit from medical treatment. So really, we summarize that by saying that everybody working in this country should have a right to occupational health services. And that declaration is something that the Faculty of Occupational Medicine takes quite seriously, and as a result of that, set up an advocacy committee and the advocacy committee has, as part of its mission, is to bring occupational health services to all employees in the state. The way to achieve that, well, I suppose the first thing to look at is what's there already. From the perspective of physicians, there's a couple of different types of people that provide occupational health services, and there's a couple of different types of occupational health services. So there are some companies that have quite a large staff, and they'll employ doctors, nurses, hygienists, health and safety officers directly, and they'll all work together as part of the multidisciplinary team within that organization, and they'll have an in-depth understanding of the risks of that organization, the health and safety risks, and they'll be heavily involved in risk assessing those, mitigating any risks, and improving the overall safety of that workplace, and therefore improving the overall health of the workforce as well. So those would be large employers. You have occupational health services embedded within An Garda Síochána, which is a large employer, some maybe 20,000 staff. The Defence Forces has approximately 8,000 staff, and we've got embedded occupational health physicians. We have some occupational nurses, physiotherapy services, clinical psychology, and psychiatry. And we have health and safety officers in every location, with different levels of training. We've occupational social workers, and then we've an employee assistance program, which is called PSS. It's Personnel Support Services. So we have a lot of people working together. We also have a chaplaincy service, and some people do avail of the chaplaincy service when they're religious and they need a bit of assistance. And we all communicate with each other, although there's consent issues sometimes that need to be ironed out before we communicate totally freely as part of that multidisciplinary team. You've got the rest of the public sector. I think about 53,000 staff would receive their occupational health service from the civil service based in Smithfield, and they'd have full-time occupational physicians working there. Certain private companies would have full-time staff as well. Then you've got private occupational health referral services. And they'd be slightly different in that they'd have a contract to provide the service to a particular company. So you could have a big employer like AIB, and they don't have anybody working internally, but they would refer all of their they'd refer any of their employees that needed to talk to an occupational health physician out to one of the private companies that provide that service. So the essential difference there is that they operate on a referral basis only, and they will see the patient once or twice, and they'll send a report back, and then that report will be relied on to make decisions around that person's employment, their continued employment, any accommodations that could be made, whether or not they're redundant or not able to continue working, and those decisions be made based on the report. There's large consent issues there, because sometimes an employee will say, well, I'll go and see occupational health, but I'm not consenting to them sharing any information with you. In which case the doctor can see and have things that they'd like to recommend, but not necessarily be able to recommend them, which well, it makes it difficult for that situation to progress, and it makes it difficult for the employer to make an informed decision about what they might be able to do with that employee. So that and then another way that sometimes people access occupational health is there's a network of there's a lot of GPs in the country who've done who have particularly working in smaller cities and towns, and they would provide occupational health services to local smaller employers, and those GPs may be very experienced in occupational health. They may have done all the exams like the LFOM, the membership exams, the fellowship exams, but are primarily working as a GP providing occupational health services. And there's quite a large network of those around the country, probably more so than internally embedded occupational health physicians or occupational physicians. So and then there's certain GPs that haven't, that only do a little bit of it. They get asked from time to time, can you do a pre-employment medical on this person, or can you have a look at this person and give us an opinion? And a doctor could give an opinion, sometimes about a particular situation, and they could give an opinion about whether or not somebody with a particular condition would be able to work in a particular area and what kind of accommodations, but without necessarily having all the qualifications behind them, they can still give a reasonable opinion, and there'll be quite a lot of doctors that would do that as well. There's a big distinction really between GPs and occupational health physicians in that when you go to your GP, your GP will advocate on behalf of the patient, whereas an occupational physician will also advocate on behalf of the patient, but with a consideration to the employer thrown in, and with this overarching principle that part of somebody's return to full health and rehabilitation includes returning them to work, and sometimes people develop chronic diseases and they're never really going to be 100%. But if they were to come out of the workforce because of that chronic illness, it tends to have a lot of negative repercussions down the line, particularly for their mental health and their sense of self-worth. And so this overarching principle that even if you do have a chronic medical condition, you're still better off if you're in the workplace, can be applied to the situation sometimes more readily than a primary care physician who's purely advocating on behalf of the patient might consider. So sometimes with respect to occupational health, and that little bit of background might assist with interpreting this slide, you can have problems with the definition of occupational health. So that kind of arises sometimes where an employer or management team might think that any doctor can provide occupational health advice, which in some cases is okay, but you have to be quite careful around that, So you would ideally have somebody who's got a particular interest in occupational health because it is a specialty in its own right. So completely ignoring the kind of training that somebody would go through to get to that level can potentially result in the advice being suboptimal, coming from somebody who isn't fully trained. And then we've discussed a little bit there about the variations across the employment sectors already, and the types of access that people have. Okay, so there are the percentage of Irish persons engaged by the size of enterprise in Ireland. So you see there's 33.6% to be large, greater than 250. And you'd be tending towards having an embedded occupational health physician when you get into large companies over 1,000. But it's not systematic, and there'll be lots of very large companies in Ireland that don't have their own internal Occ Health team. They just contract it all out externally. So this is considered the percentage of workers covered by an occupational health service around Europe, and you can see there that Ireland is in and around the less than 30%. Okay, the EU average 70 to 90%. So in that respect, we're doing quite poorly. We're doing even worse than our counterparts over in the UK. The Faculty of Occupational Medicine is a kind of an all-Ireland faculty with members from Northern Ireland as well. And so it's interesting that they've got better cover in the north of the country than we do down the south. And that's despite our best efforts. But as I say, we have the advocacy committee and the faculty very much approaching companies in mind with occupational health as a worker's right, an EU worker's right, and that should bear fruit over the next few years. So I just have a little case study here, and this is just there's a couple of these thrown into the slides. We have a 26-year-old male assistant, John, working part-time in a temporary role, develops low mood, anhedonia, and difficulty sleeping, anhedonia being just unable to enjoy anything. Living with housemates and has poor social supports. So you might consider if he has access to an occupational health service that the manager might notice that he's having some difficulties in referring to that service. You get a work-related stress risk assessment carried out, be signposted to the employee assistance program, and if there's other supports such as counselling, psychology, social work, you might be signposted to those too. John then attends the occupational health service, recommended to continue in work as the symptoms are manageable, but to attend his GP for consideration treatment of the underlying mental health condition. So he attends his GP, attends the employee assistance program, commences treatment, symptoms improve, and he remains in work, potentially on light duties, limited shift work, things like that, without necessarily triggering a lot of sick leave and loss of earnings. Whereas if you didn't have access to an occupational health service, it could look a little bit different. The manager noticing a change in performance, for example, and tells John that he needs to improve, or else. I'm not too sure why it says Peter there. So symptoms then deteriorate, and he comes under pressure from work, and everyone gets a little bit irritated with him because he's not performing. Ends up going sick from work, isn't contacted by the manager, and eventually GP just keeps sending in sick notes. And because his mental health disorder hasn't been appropriately managed, his depression hasn't been appropriately managed, that could deteriorate and end up going to the emergency department with suicidal ideation. So there's it's just an exercise in thinking about how things might deteriorate without the supports. So any of the supports that you have in place in any workplace are usually very valuable. So the World Health Organization defines health inequity as systematic differences in the health status of different population groups. And you can imagine that there's huge health inequality throughout the world. The most obvious example of that is in the United States, where there's huge health inequity within that country, where if you have insurance, you've got access to the best healthcare system in the world, the most advanced treatment options for all sorts of things. Whereas if you don't have it, you have access to nothing. There's a few private clinics, a few public hospitals, but they're completely overrun and under-resourced, and it's very difficult to access the kind of healthcare that you need. So it's you can see it, and then in Ireland we're pretty good. We do have a bit of a dual healthcare system between public and private, but even if you don't have access to the private system, you do have access to very good care in the public system, with the unfortunate bottleneck of getting into it. You're either going to be very delayed on a waiting list, or you'll be very delayed in the emergency department and maybe turned away a couple of times before you get the care that you need. If we consider work, the average person in Ireland will work 33% of their waking hours, 36 years of their life. So they're going to have exposure to a lot of different pressures and stressors, and work has to fit around their life. Their life has to fit around their work. Occupational health then is uniquely placed to support all people in the workplace. There's occupational health, particularly in hospitals as well, supporting doctors, nurses. So you'd always have those kind of supports in the hospital, where they'd have a number of functions within the hospital, but providing support to the doctors and nurses and other staff would be one of the main things that they do. So we'll just move on again, because I'm just conscious a little bit of time here to this next case study. If we had a 32-year-old male pilot working on the emergency air ambulance service, which flies out of Athlone, has a new baby at home for the past 4 months. His wife is suffering from postpartum depression, and he's 4 days of a 10-hour residential shifts in Athlone. So he's meant to be away from home now for the next 4 days. Again, if we look at crew resource management principles and occupational health support, the captain at the start of every shift on the service, the captain will give an opportunity for all staff, aircrew, and National Ambulance Service staff to go through any risks to the mission that morning. So you might have 2 red flags with respect to our pilot here: fatigue and stress, if we were following the I'm Safe checklist, which I have on a subsequent slide. As a result of that, the pilot will be grounded and referred to the Occupational Health Service. Now that, in practice, might actually ground the whole mission for that day until a replacement can be found, but that's the benefit of having a robust CRM process, that you put the mission first, and you're not going to jeopardize the mission and force somebody to fly when they're not able to do so. You might refer the pilot to the Occupational Health Service, and then also to the Employee Assistance Service. You might reasonably accommodate the pilot's working schedule by allowing to work flexible hours in support of his partner at home, maybe working close to home and just working 9 to 5 in the usual office, and not necessarily be on shift away from home in a different city. Situation would hopefully improve over a number of weeks. The pilot remains contributing in work, albeit in an adjusted role, and then he returns to flying duty when the home situation improves and he feels supported and enthusiastic to return to his role. Similarly, if we didn't follow those principles, The pilot might try and push through, distracted by the thoughts of home and how he'll support his wife after this block of shifts. The captain then may notice a deterioration in the quality of his flying, poor reactivity to flight data and air traffic control instructions. Captain could recommend that the pilot is grounded due to poor performance, and the pilot has an adverse stress reaction to the lack of support, loses interest in his occupation, affecting his mood, and his relationship with his wife deteriorates. Doesn't access the appropriate supports and obtains sick leave from the GP. After a period, he's brought in to explain his long absence to an unsympathetic management team. So, very different scenarios again. This kind of thing it really doesn't happen very frequently, but you can see how it's very easy for something like this to happen. Having a family is something that a lot of people will go through in the workplace, and it can have a hugely distracting effect on them, particularly with respect to sleep and the additional stressors. So with respect to occupational health, then we do have a strategy, call to action by Professor Ken Adley and Zoe Healy. And this was with respect to rolling out and introducing occupational health to more employees in the country. The key recommendations really are that the faculty is ready to establish an advocacy committee, which they have done, engage one-to-one via forum with priority stakeholders in the college, that's the College of Physicians of Ireland, and across all of the medical schools around the country to get candidates interested in the specialty, and also then to approach businesses and ensure that each business in the country has some kind of occupational health support, and that'll be kind of the minimum that we'd hope to achieve. Build out, we'd be looking to create an infrastructure to support this advocacy, initiate engagement with all the key stakeholders around the country, and work with them to build on the strategy over time. This year, 2026, is the 50th anniversary of the Faculty of Occupational Medicine. There is a Society of Occupational Medicine as well, the Irish Society of Occupational Medicine, which is, I think, in its 80th year this year, being founded in 1946, whereas the faculty came along in 1976. So there's going to be a few additional events throughout the year to celebrate the 50 years, mainly the spring conference. We would have a spring conference, an autumn conference, and a Smiley lecture each year anyway, but it'll just be enhanced this year to celebrate that anniversary. Just a couple more slides then with respect to human factors, that I was conscious of who I'm presenting to here, really. So, I mean, we'd see in occupational health that human factors, ergonomics, are intrinsically linked, part of the interaction between people, their work environments, promoting health, safety, and performance. And I think we would have a shared goal in improving the health and the health of the workers, ensuring a safe working environment, and everyone feeling supported. We are big advocates of crew resource management as our kind of formal approach to human factors in the Air Corps. Crew resource management, you may be aware of that in aviation, as its origins in the 1970s. There was an accident in 1977 where two Boeing 747s crashed, resulting in 583 deaths in Tenerife, in a small airport in Tenerife. It was following a diversion of those aircraft from Gran Canaria, which happened because there was a terrorist incident in the main airport in Gran Canaria, so they diverted a lot of flights. So the place where this accident happened in Tenerife was quite a small airport comparatively, and really was just overloaded with traffic that day. There were the main modules within crew resource management, which we insist that all of our air crew do the training and maintain it on an annual basis. It's all about decision making, being assertive, analyzing the mission, communicating effectively, good leadership, adaptability, and situational awareness. The assertiveness sometimes falls down and can be tied in very much with communication. So, if a staff member has to be willing to participate state their position, and present in a way that's understood by others. So clear, accurate communication, but also being assertive sometimes, which can be difficult as well. If junior staff members aren't empowered to be assertive through training such as this, they may not do so. We did have a very real um, um, demonstration of this. Now, this was before my time, but it's something that we discuss in crew resource management training, where the old Dauphin helicopter was called out to a search and rescue mission at the Slieve League Cliffs. This was about 20 years ago, and there was it was at night, and the weather was very poor, and it was a bit drizzly, so the visibility was poor as well. And there was the senior pilot um, delegated to the more junior pilot, who was a fully trained pilot, but also quite junior in terms of rank and experience, and just told him one thing: to keep an eye on the cliffs and make sure that make sure that you maintain the orientation of the aircraft. And while they were flying around, um, doing circuits of the uh, area of water that you see there with the two big rocks in it on the picture. Um, the pilot who was mainly at the controls doing these circuits, um, he kind of he describes it as he got the heebie-jeebies, and he found that he wasn't too sure. He didn't really feel like he was orientated in space. So he had this kind of spatial disorientation episode, and he thought at the time that he was over the water outlet, and didn't have cliffs around him, and he was just about to turn when the more junior pilot, whose sole focus was maintaining orientation and making sure he knew where the cliffs were, shouted at him, "Do not turn that way. Uh, do not turn." I think it was do not do not turn left, which is what he was going to do. You must turn right immediately. And the more senior pilot trusted him so much because he felt like he was disorientated, and so he turned right. And he felt genuinely that he was going to crash into the cliffs when he turned right, but because he trusted his more junior colleague, who asserted himself and communicated very clearly and showed great leadership, the helicopter just flew up in the air instead of flying straight into the cliffs. So they did report that as a near miss, and it apparently turned out that there was nobody in the sea even at the time. It had been a prank call made by a person up in Donegal, which wasted all those resources and put all those lives at risk. So within aviation, then I've mentioned it before, the I'm Safe checklist. You've got illness, medication, stress, alcohol, fatigue, and eating. So anybody comes in and says, "Listen, I'm too stressed to fly today," or "I accidentally had too many drinks last night and I don't feel like I should fly," or "I wasn't able to sleep because the kids are up all night," anything like that, and that can jeopardize the mission, and the pilot. In fact, all the crew are obliged to declare that. From the Federal Aviation Authority in the States, you've got the 5 Ps. You got the plan, which is your mission, the plane, the pilot, the passengers, and programming. And the part of that acronym there that's really assessing the pilot is the I'm Safe checklist. And that's fairly ubiquitous to crew resource management within aviation, and something that we've very much adopted here. We'd also consider ergonomics in the workplace, particularly in the Air Corps. I have a bit of a joke that I say to all the pilots, that the biggest risk factors for a pilot, is for a military pilot, a military helicopter pilot, is neck pain and dying in a ball of flame. So we do consider the positions, how they fly, how they carry themselves, the equipment that they use, and do those kind of assessments. Now, we don't have a massive amount of choice. We have the aircraft that we have, but we do have a bit of choice, much more so around the office, and we make sure that we do ergonomic assessments. Now, I don't do them, but we have a physiotherapist who comes here, and she does all the ergonomic assessments. So focusing, as you know, on designing the workplaces to fit the human body. There's considerations really sometimes on whether or not this is employer-employee responsibility. We tend towards saying it is the employer's responsibility, but then you've got certain employees that work from home, and to what extent is the employer going to ensure that the ergonomics are set up correctly in their home working environment? Some places will give staff members a certain amount of money to buy equipment. They might refund the purchases of chairs, or they might just say, we don't trust you to buy the right one, so we're going to buy this chair for you and deliver it to your house and set you up with all the appropriate equipment. So different places have different approaches to it. We had an interesting one recently where ergonomics came up. It's a 46-year-old pilot, and he was promoted to an office-based job, and he presented to his aeromedical examiner, which was myself, with severe neck pain, tingling in his C5-6 nerve distribution, which is kind of around the thumb in his dominant arm. And we did an MRI on him, revealed disc bulging with severe right foraminal stenosis and C6 nerve root impingement. So I was chatting away to him anyway, and it turned out that he got promoted, and the guy who left had bought himself he bought himself a nice chair, not the one you see in the picture. He bought himself a modern chair that is designed to allow people to sit in it for 8 hours. And when he left the job, he took that chair with him. So the chair that was remaining was one of these antique, what's called a captain's chair, and it was quite a nice chair. But our 46-year-old pilot then came into the new office. He saw this as the only chair, and he proceeded to sit in it. And very busy job. He was basically in the office for about 10, 11 hours a day, and found that his neck pain was really deteriorating. It's also much shorter than the guy he had taken over the office from. And the guy who had taken over the office from had an ergonomic assessment and had the desk and the chair and the phone, everything set up for a man of his height, whereas the chap now occupying that area was much shorter. So we discussed it. We asked the physiotherapist to do an ergonomic assessment. We had a new chair purchased for him, and referred him in to see a neurosurgeon. But thankfully, with some conservative management and change to his working practices, he improved without the need for any complex interventions. Okay, so that's everything that I have for you today. If you have any questions, I'd be happy to answer them if I'm able to. And if I'm not, I can probably get the answers for you and then send them back in through